Welcome back to Midnight Med. This video is on colorectal cancer. Colorectal cancer can have varied clinical presentations. Some key presentations might include blood in the stool picked up on a fecal occult blood test, other changes in bowel habit, abdominal pain, anemic symptoms like pallor, tachycardia, and shortness of breath, weight loss, and other key constitutional symptoms like myalgia, fevers, and headaches, especially in the case of advanced disease. And some may also be asymptomatic, and this is more common in right colon cancers than it is in left colon cancers. So, how do colorectal cancers develop? The normal colorectal epithelium develops progressively into polyps and then neoplasms by accumulating mutations in specific genes that lead to hyperproliferation and poor differentiation. The two key pathways implicated are the adenoma-carcinoma sequence, which is based on mutations stemming from chromosomal instability and microsatellite instability, and the serrated or alternative pathway, which is based on mutations arising from microsatellite instability and CpG island methylation. These different pathways and mechanisms are based around different mutations, but ultimately result in the same result: the development of a cancer from normal epithelium through various grades of polyps and adenomata. The schematic here illustrates the microsatellite instability mechanism on the left and the chromosomal instability mechanism on the right. Microsatellite instability leads to mutations in mismatch repair genes, BRAF, TGF-beta R2, and IGF-2R, while chromosomal instability leads to mutations in APC, KRAS, SMAD2 and 4, and TP53. The accumulation of such mutations may ultimately allow the invasion of neoplastic tissue beneath the basement membrane of the colonic epithelium, leading to the spread of the cancer to other sites. Some key risk factors for colorectal cancer include smoking, alcohol consumption, obesity, inflammatory bowel disease, so that's Crohn's and ulcerative colitis, being male, having a family history, having a genetic syndrome like FAP, which is familial adenomatous polyposis, try saying that one 5 times fast, or Lynch syndrome, having pre-existing polyps, and consuming excessive amounts of red or processed meat. The key investigations undertaken for colorectal cancer would firstly be a fecal occult blood test for screening for the asymptomatic individual. It's generally offered to the public depending on age. In certain countries, it might be after the age of 45 or 50, and you might do it every 2 years. But for definitive diagnosis, the main investigation would be a colonoscopy and a biopsy to identify suspicious lesions and confirm their nature on histopathology. Staging is done using CT or MRI, and eventually with surgical samples from tumor or lymph node resections. The table here summarizes the key staging distinctions drawn using the AJCC and TNM staging systems. For simplicity, we'll just run through the AJCC system here. Stage 1 is where the tumor is confined to the submucosal or muscular layers of the gut. Stage 2 is where the tumor has invaded beyond the colonic muscle layers and potentially into other structures and organs. Stage 3 is where there has been spread of the cancer to regional lymph nodes. And stage 4 is where there has been metastasis to distant sites. Onto the management. The mainstay of colorectal cancer management is resection of the tumor. This can be curative alone for early stage disease. The resection can be endoscopic if the cancer is low risk, and that's for mostly early stage 1 cancers. Surgical resection with resection of lymph nodes is typically undertaken for cancers of higher stages. In palliative patients, surgery may sometimes be considered as well. Chemotherapy and radiotherapy are generally used in more advanced cancers. These are used as neoadjuvant therapy, that is, before surgery, in locally advanced rectal cancer, so stage 2, stage 3, and as adjuvant therapy, that is, after surgery, in stage 3 cancer and beyond. These therapies are also used systemically in unresectable metastatic disease. Some of the common chemotherapeutic agents that are used include capecitabine, 5-fluorouracil or 5-FU, oxaliplatin, and targeted therapies. So that's it. Thank you for watching. Don't forget to like, subscribe, follow us on Instagram for more, and we'll see you in the next video.